Hi, Victor Montori, Mayo Clinic. Thanks for a very good presentation.
Thank you.
I'm disappointed I didn't get offended. I was looking for it. The Cheesecake Factory thing, I think, just went through the threshold. In your Atlantic piece, the newspaper piece that was published at the Star Tribune in Minneapolis put it together as well. You make the case that you find there's insufficient for-profit healthcare. And you were not here, but in the previous panel, we were talking about how there is actually good evidence that for-profit healthcare is actually more expensive, and it has associated with increased mortality. And I suspect that it's because of the conditions or environment in which it learns to operate. You're suggesting a fundamental change in the conditions of an environment. Do you want to elaborate a bit on that?
Well, thank you for bringing that up, because you've made the point for me, but I think it's so important it's worth pointing out. We have the worst of both worlds. We have a profit-driven system with the wrong customer. And so your point is exactly right. The incentives are, first of all, there are no nonprofit systems, right? We're all working for a living. So at some level, all of us are doing this to pay our way. There may be no shareholders, but there's still people earning a living, and how they're incented is important. But your point is completely correct. I wrote a piece for Bloomberg about 2 months ago saying, the profit-driven system is producing terrible results. The nonprofit system is delivering, for the most part, terrible results. The problem is the incentives, the economic incentives for both are fundamentally the same, and they're distorted by the fact that we've decided to let an intermediary be the customer for everything. And I would argue that between the market power that these intermediaries have allowed providers and that the intermediaries themselves have, and the political power accumulated, the way to make money in healthcare is, for the most part, to do bad things. And the fact that we don't do terrible things speaks to how many good people there are in healthcare. Because, in fact, purely economically, I mean, if healthcare was an investment bank, remember what we have. We have a system that says, we'll pay for any care the patient needs. And we've got somebody with a monopoly on determining how much the patient needs. If in investment banking we said, we will subsidize any deals bankers think are worth doing, we would be an entirely deal-based economy. The only reason in healthcare we're not, again, is because the professional requirements of people. But I think those incentives can be changed meaningfully. And without them, the for-profit system, the not-profit system are both going to produce terrible results. And the relative difference, I can't tell.
I agree with you. I feel like you're my twin. And I wanted you to know that in Portland, we have been trying to get the consumers in Portland to design a new benefit package, to ask for warranties for certain services, and to change things up substantially. And one of the orthopedic, actually it turned out to be a large orthopedic consortium, got together and redesigned how they're going to provide services, and they're going to charge one flat fee, and they're going to give a warranty for services. So if anything goes wrong for a long period of time, the patient can come back and know that that's all covered under the warranty. And because of that, they built in shared decision making to make sure that people who get the services really want the services. They prep the patient much more upfront, and then they prepare them for after the fact, including how to rearrange your furniture, so when you come back, and what to do with your throw rugs, et cetera. And so I think it is very important. The second thing I want to tell you is a couple of years ago, we had the author of a book called The Healing of America come to Maine. I think that's why he won't go anywhere else. The poor fellow, Maine's 8 hours long, and we took him over most of Maine. We reached 16,000 people, and we had over 1 million media impressions, which in Maine is good because that's how many people we have. And what I learned from going over most of Maine with him is that our system has a lot of unnecessary, unvalue-added costs, beginning with just how we reimburse for services, and that each of these insurance companies have a different way of doing things. It's not uncommon for practices, for hospitals in Maine, to have twice as many people who are doing billing than they do beds in the hospital. And they have very expensive computer systems that they have to work. Most countries have one electronic medical record that they buy for everybody. We have 1,000, and everybody everybody has to connect to those different thousands. So I think we don't do a lot of things to try and make sure that we get more value for our system. And when we keep on paying for insurance the way it's offered to us and not ask for something different, we are contributing to the problem.
Well, thank you. One point that you raised that I think is worth thinking about. One of the things we think about in healthcare that we actually don't think about in anything else is that there's the right way to pay for things. In everything else, we're willing to have things exist side by side. Different business models, different ways of paying. I think it's actually a mistake in healthcare. I think one of the nice things about bringing consumers into a more balanced role is that we'll have people compete for their business on different things. That people will bundle their services and say, here's my package you can buy. Others will do fee for service. In fact, rather than sit around and say, what's the right way to pay, I think what we need to think about is that having different business models exist at the same time is the feedback loop that causes endless innovation and endless improvement. There are very few things on earth that there's only one way to buy, but in healthcare, our best minds are endlessly looking for the perfect way. And I think that conceptually is an error. The other thing I should mention is when I talk about patients, what I'm really talking about is balance, right? Bringing consumers into the system, not having everything be intermediated, doesn't mean you get rid of the government role or you get rid of insurers' role completely, but it does mean rebalancing the system.
I'm Christine Bechtel, and I work for a consumer advocacy organization here in town. We met earlier. And I want to fundamentally ask you, what's the pathway, right? That's sort of the theme of this meeting, and I think conceptually, there's not much that you've described that someone in this room is going to say, oh, he's, that's not the right idea in terms of a way. Right. But the question is way to get there. And I want to preface that question by saying that historically the words consumer-driven healthcare have a bad connotation for consumers because that's usually the place, like high-deductible health plans, where we just voice the problems that the health insurance companies and the employers and Congress have been unable to solve, so let's get them to fix it.
Right.
I don't think that's what you're saying. But I think, on the other hand, it would be helpful to know what's the pathway, next 3 things we need to do to make progress in that system. Is it blow up the insurance companies? That's kind of what I heard. Is it end meaningful use?
Well, I mean, my belief actually is the more that consumers pay out of pocket, the more good things happen, including meaningful reduction in prices. I mean, interestingly, before we decided that preventive care should be covered without a deductible, we were starting to see real competition in the preventive care services. We were starting to see minute clinics that did things for fractions of prices available in the mainstream healthcare system. And that's what you see, right? If you've spent any time in communities that are heavily illegal immigrant, you actually see how a cash-based healthcare system works. We're all of the belief, oh my God, if it costs less, it can't be good. And some of these are good and some of them aren't good. Obviously, these aren't the best customers in the system. They're the lowest price paying. But in fact, systems do develop. So what can we do? Well, I think some of it's about to be done for us. The reality is we're a couple of years away from no company in America being able to offer anything other than very high deductible healthcare insurance. And when you get that sort of scale of people paying out of their own pocket, I suspect you'll see the provider industry start to reorganize itself to get their business, and the same thing that we were seeing in preventive care before the Affordable Care Act. I've called for, insurance to shrink, to cover only the most catastrophic things, to give benefits to people. I mean, I'm spending $25,000, $23,008 for an employee's family plan this year, standard deductible. I think if you had a very high deductible, say somewhere in the $15,000, $20,000 range, that sounds very high, I know, the premium is probably somewhere in the $5,000 range, 5, 6, 7, which means I could write that person a check if it was tax neutral for $15,000 a year, which means they basically have enough money to cover their deductible every year and a half, 2 years. And the reality is that most of if you had millions of people with that as opposed to just those who were too disadvantaged to have anything else, I think you'd have a very different healthcare system. Same amount of money, just flowing differently into people's pockets and into the system. But I must admit, it's very hard to get political support for that. I think what we're going to see happen is it happen anyway. When you look at how the exchanges will work, there is the cost of health insurance, standard health insurance, because of the exchanges is going to go through the roof. There's no other way they can work, right? They're price capped. None of their customers care about prices. What does that do to prices? It causes them to go through the roof. And that's going to drive the rest of our businesses. They're already high to begin with. I think you're very close to seeing the end of standard deductible health insurance privately offered outside the government context. And that'll change. That'll make a big change.
Yes. My name is Perry Cohen, and I'm a Parkinson's patient. My first job, after I got my master's degree, was with Massachusetts Blue Cross Blue Shield. I was an analyst. And one of the things I learned there is that insurance, you talk about insurance. Insurance was the insurance that the doctors in the hospitals get paid. It really wasn't patient protection. So well, I'm going to have to pass on.
Well, can I address your point, though, Perry? I think one of the strange things about public policy debates about healthcare is the role that's assigned to insurers. You hear politicians talk all the time about relying on insurers to control the cost of care. I guess none of those politicians have been in the insurance business, because insurers have no way of growing their profits by demand for care shrinking. And demand for care is volume times price. And what people get confused by is when they put in a claim, an insurer says, like mine did, nope, sorry, we're not paying for that. It sounds like they're pretty tough on cost. But the fact is, we've had private insurance dominate pay in this country now basically since the mid-50s. We've seen costs go up much faster than GDP and inflation, and insurer profits have been fine. There's a reason, if you spend time in other insurance businesses, for example, when there's a hurricane, the stock prices of all casualty insurance companies go up, not down. Why? Because premiums are going to go up, margins go up. The idea that insurers are going to somehow bring discipline to a system, if none of us needed any health care, insurers did such a great job of driving a better healthcare system, we're all so healthy, there wouldn't be health insurance. They'd earn nothing. And so insurers at best have an ambivalent relationship with cost. They don't want to pay for your procedure, but they do want your company to have higher premiums next year. That hasn't made them great guardians of the system, at least in terms of cost, and I think many of us would probably argue they're not great guardians in terms of quality and safety either. I don't know if that gets at your question or your point.
Yes, it does.
Thank you.
But the point I was trying to make is that patient, the healthcare system is really more doctor and provider centered rather than patient centered. And I like your idea of having the patients be the purchasers more so.
Well, thank you. I think we're unable to achieve the balance that a lot of people in this room have been talking about the last couple of days unless you bring the economic incentives in line with the therapeutic ones, which is to have patients take more control, be more active. Doesn't mean they all will, but it means the system will push that more on them. In the same way that in any other industry, things are made easy for us. The healthcare system does the opposite. We've got to do the work if we want to do the work. That shouldn't be the case.
Well, there is an advantage of patients being involved.
Right.
Healthcare advantage.
Right.
So,
and that's where this comes from. This comes from that more than economics, because I think unless the economics match what you're hoping to accomplish, you're not going to accomplish it.
thank you.
Okay,
Thank
we'll
you.
have two more here, and then Lynn.
Just a couple, not as an argument for status quo, but just in looking for an expansion of the concepts, is competition requires more than one provider, and in small town America and rural America, there may not be enough room to make investments for more than one provider group or a set of hospitals, et cetera. The current system creates, of course, that sort of environment, and there is competition that emerges in small cities where you have hospitals that are duplicating capacity to the same work, and then, of course, getting patients through it in order to pay for it. And in the reimagined system that you have, how would it work, not in New York or in large urban environments, but what happens in rural America, in environments where competition may not be able to play out?
It's a great question. In a reimagined system, it really does look like other things, which is there's also not enough scale for competition in most goods and services in rural America. What happens is, and I think this is more likely to happen in healthcare than anything else, is that the competitive price in truly rural areas is the cost of traveling to a less rural area to achieve a service. That's what keeps anybody from charging insane amounts in rural areas for anything. Healthcare is actually not that different. And it's a very difficult thing for people to understand that, we have plumbers in rural America, right? They can't charge you $1 million to fix your faucet because the town is only as, 1,000 people and therefore only one plumber. That plumber can only charge what it costs for the plumber from the next big town to drive over. That's the only marginal difference he can charge. In this country, in healthcare, we've somehow decided healthcare is so different that we need to regulate the rural markets in such a way to assure there's never any competition. It's all we've done. And that concerns me, right? Because it's not, again, there's lots and lots of expensive goods and services consumed by people in rural America. The other day someone said to me, the problem in healthcare is, I agree with you that much of healthcare is now about things that we have time. They're chronic illnesses, I'm going to have my hip replaced. There are all sorts of things we actually can make a decision, and we have time for the system to say, use this procedure instead of that, this one's safer, that one's cheaper, this one's whatever, right? There's time for that decision making. But a lot of healthcare is still about emergency stuff. And how can that possibly work in a consumer-driven system? So if you ever had a flat on a highway, you know that the tow truck that came to you, or whoever came to you, didn't say, let me see your balance sheet before I decide how to charge you for this. That the economy figures out ways to handle emergency services. Most people prepay that stuff, right? So that they know there's somebody there at a reasonable price when they have a flat tire. But even if you haven't prepaid, there's a limit. And that limit is created by really functioning markets existing around us. One of the problems with billing $640,000 for killing somebody, when you know you're never going to collect, it has nothing to do with cost, price, reimbursement, anything else, is that none of us have comparable prices to even think about. There's no market for anything that's real in a way we can understand it. So I'm not disagreeing with your point. It does cost more to live in a rural area than an urban area. But it costs a certain amount more, and it does in every other good and service.
Hi, thanks,
I'm
David.
sorry,
My name is...
Lynn's going to need to be the last one.
Thanks, Mark. Hi, my name is Lynn Paget, and I'm actually from Boston, Massachusetts, and I have about 18 questions for you, but I'm actually just going to ask two quick ones. One is that we, of course, have pretty active exchanges, and in addition to working in the health policy arena, I own a small business unrelated to health, and quite frankly, I haven't seen the competitive pricing from the exchanges that I would hope to see. Second is, I agree with you completely on the high deductible plans. That's our future. But what do you think the protection mechanism is going to be to keep those premiums from at some point matching what we're paying now without a high deductible? And then that was my number one question. My number two is, if there was one thing you could pick as a disruption similar to the container, what would it be?
That's a really good question. So let me ignore it. First of all, just quickly on the exchanges, any business that competed on price on an exchange how structured is beyond stupid. It's never going to happen. You tell somebody you cannot underwrite, you cannot design the benefit package, compete on price, it's going to be one price on every exchange. It may not happen the first year, but it's inevitable. Exchanges were designed by people who have never bought or sold anything in their lives. That's the only explanation for it, right? They've never competed in anything ever. They think it's supposed to be like commodity exchanges, I guess, but in commodity exchanges or Expedia or wherever else they use as an example, you don't care who the customer is. So you offer this broad range of products, and whoever has a credit card can buy it. In insurance markets, all you care about is who the customer is. And you have to be completely blind to that. No one's going to compete on exchange. It's going to be a wonderful mechanism for raising prices. But in terms of, what's disruptive, my argument is what is truly disruptive, what changes everything, is that we're paying out of pocket. And that rather than look at these thousands and thousands of goods and services as a single thing, healthcare, we say to ourselves, there are some things, some people, some conditions that need insurance. Born unlucky, terrible accident, You know, it got one of those diseases that's just horrible, right? We need to ensure that as a society because we want to. And I actually believe in national health insurance to cover that. Single pool, all of us. A lot of healthcare is just routine, just like anything else. And insuring it makes it less responsive, higher priced, and of lower quality. And then there's stuff in the middle, which we save for. We're used to this, right? Most people in this country actually will buy a house at some point in their lifetime. None of us have problems with the idea that the down payment comes out of savings. The bulk of it we borrow, depending on what stage of life we're at. If we're older, we may just pay for the whole house because we've had savings, right? Routine maintenance comes out of our pocket. Accident comes out of insurance, fire, house burning down. None of us have problems that there's 4, 5, 6, 7 different ways at a time we might fund our shelter or our food. Nobody says we need to pay, we need to pay for the poor to have food the same way we need to fund upscale restaurants. Nobody says that. No one seriously says that. But in healthcare, which is the broadest possible range of goods and services, we somehow think it all has to be the same way. And that's enormously distortive to the system. So once we start paying for more and more of it, and it needs to be real scale, it can't just be the poorest of us who pay out of pocket. It's got to be all of us who pay out of pocket. This industry will restructure itself like every other industry on earth did. 1965, the customers of the computer business were NASA, the Defense Department, the IRS. The customers of the computer business are sitting in this room. That change, it happened because somebody said, you know what, I can sell to those folks. Changed everything. The last point you made, which is the hard point, how do we just stop it from happening all over again just with catastrophic? I have a half-baked answer to it, which is in my half-baked book. And that is we should think about moving to defined benefit. One of the interesting things about healthcare, of course, is it's got very little marginal cost. So prices have a lot of room for variation, which means the actual cost of providing a service is relatively low, no matter what people think, right? Once you bought the equipment, this is true of industries like airline, software, telecoms, but the actual marginal cost of producing a pill is almost nothing, right? Of providing a physician service is the physician's time, which is a wide variation of possible price. Of using a diagnostic machine, it's almost zero, although because the market's dysfunction, they actually charge you for that, but they shouldn't. If you actually had a defined benefit system for catastrophic care, say, we're going to collect $1 trillion of premiums, we're going to pay out $1 trillion according to this schedule of diagnoses, the entire system would have to reorganize itself to fund care at that price. And it's so different from the way we think about it now that I don't push it. Because if we can move to catastrophic, would be 10 years before what you mentioned happens to the point where we have to think about it. But ultimately, at some point, we want to say, we want this country to be healthy. We're not going to spend so much money on healthcare. We're going to spend more money on consumption and recreation and environment and diet and exercise and lower stress in our life. Those are the things that drive health. And the only way to do it at some point is for some part of the system to probably have a budget. The catastrophic function probably should. But that's a little theoretical at this point. I think it's half-baked. Thank you, though.
This is Daniel Wolfson. I spent most of my career actually with prepaid group practices. And one thing that we realized, even though we were capitated a group, that in changing the incentives was just half the game. It was really the start. So I wanted you to react to that because I think it's a little bit more complicated than that, just changing the incentives. We've been talking about shared decision-making here and the difficulties of that. And the other thing is, you know, there was Shelley Greenfield was here yesterday, and he did a study a long time ago that showed when you increase the cost to the consumer, you delay care, and it was a trivial amount actually at that time. So I wanted you to react to that, and I guess you're leaning, and you haven't said, maybe you haven't said this, but maybe you did, is you're leading towards consumer health savings accounts.
Oh, no, I do believe in health savings accounts. I believe in mandatory catastrophic. Basically what I say is let's take what I think is the best idea on the left, which is single pool national insurance. But the best idea on the right, which is leave as much of healthcare as possible to become a normal industry. And I think the way to do that is to shrink insurance to catastrophic, make it mandatory. Because our system starts at such an insanely high price point, we can only really pay for it with savings accounts. We can only really let people save against it until the prices start coming down to a point as they have, for example, in Singapore. The average person in Singapore health savings account would fund 11 hospitalizations as of 2 years ago. I don't think the average person's savings account can afford one, not health savings account, period, just to give you a sense of the difference. I want to talk about incentives, though. The key to incentives being incentives and not goals is they have a natural feedback loop. When the government has meaningful use rules, you got to hit the numbers, you got to hit the targets. When we have hospital readmission rules, you have to hit the numbers, you have to hit the targets. Same with hospital infection and all the other things that are going to have bonuses and penalties and all that. Doesn't ever work. Doesn't ever work. The feedback loop that consumers provide is we don't know what's going to attract them next year. We don't know what's going to work, right? That first dry cleaner who went to an IT system, so you got a fancy computer printout bill instead of the usual 12 shirts written down, right? He got a lot of customers. And the guy across the street saw it and said, God, I got to do that. He's not losing any shirts. Customers are more impressed. He seems more organized. I got to do that. Okay. So he did that, and he said, I got to add something because I'm doing it. So he added, I divide between shirts and pants, or men's and women's. I mean, if you've been to dry cleaners, you can literally see this in action, right? It never stops. It never stops. The bill I showed you from the high-price guy is going to be the bill that the low-price guy has in a year or two. The key is a feedback loop. My first meeting of Leapfrog, when they said, what was my view of what would finally cause hospital-related deaths to end, I said it would be a billboard that said, go to Uptown Hospital, downtown will kill you. We're so used to, it's funny, somebody said to me, I would never go to a hospital that advertised, because it just tells me something about their commercial approach. And I held up my iPad. This person was a big techie person. I said, I almost didn't buy this because Apple advertised it. I thought, shouldn't they be spending that money on research and design? I'm a little suspicious. How good could this be if they had to tell me about it? And really, we think healthcare is so different. We don't think to ourselves that one way to solve quality might be to have competitive advertising. It's a feedback loop. And there's no incentive that is a silver bullet. Nothing. It's the accumulation of who am I responsive to? And yes, some of it will wind up being petty, right? Customers will wind up preparing hospitals that are painted in this year's color. That sounds terrible to people in healthcare. But outside of healthcare, if you're used to serving consumers, it gives you a chance to prove you're responsive. If you spend any time in a hospital as just a patient, it is astonishing to you how hospitals have fallen so far behind the DMV. Not to mention any single consumer business on earth. At every single stage, you have to be told you're just a patient. And again, it's not because the people are bad. The people are great. Trust me, they're much better than bankers. But if you're a customer of an investment bank, you're made to feel like you're a prince, because they're going to charge you a lot of money. In hospitals, we're all spending a lot of money. All of us are spending $1 million over a lifetime, and we're all paupers. And again, we talk about money a lot, and I think you probably want to wrap up here, Mark, but we talk about money a lot. This isn't about money. It really is about incentives for quality care, safety, appropriateness, and I think that a lot of what you're talking about in here, which is having a doctor-patient relationship, a provider-patient relationship, that brings to bear what you need for the best outcomes, which is a patient that understands there's no one out there taking care of him, except for him. So I think it will add to all the work you're doing in here on that subject. Thanks very much, Mark. Thank you.